Okay, thank you very much. So I'm going to talk to you about a new TAVR system, Navitor from Abbott, and the main feature of it is new active sealing technology. So to talk about the system itself, the TAVR system from Abbott consists of a delivery system called FlexNav, which has been available for the last couple of years. That provides low-profile access down to 5 millimeters and 5.5 millimeters with a hydrophilically coated integrated sheath. It's a very deliverable system. It's also recapturable, repositionable, and retrievable. And as I say, this has been in our hands for the last couple of years. Just to show you what this means, this is a homemade video from my cath lab, with the first generation Portico system on the top being simultaneously unsheathed with the new FlexNav delivery system on the bottom. And if you imagine the scissors are the reference point, you can see that the old system had a tendency to dive into the left ventricle. That's now not the case with the FlexNav system, as you'll see throughout the complete unsheathing of this valve, albeit on my cath lab table. This is a very stable delivery system for a valve platform. This also occurs if you're in a hurry as well. So this is the case I'm about to show you of somebody who post-valvuloplasty went into complete heart block and had severe aortic regurgitation and was hemodynamically unstable. And this is the real-time deployment of a Portico valve using the FlexNav delivery system. So nothing speeded up. This is real-time deployment in a very unwell patient, and pleased to say that the stability facilitated safe and effective delivery of the valve. What about the new valve? So I've talked about the delivery system. This is the new valve that is now available. It's called Navitor. It has a number of features that have been changed from the old generation Portico valve. It comes currently in 4 sizes from 23 to 29, but perhaps the most important feature is a new outer fabric cuff called Naviseal. This is an active cuff that fills in diastole to actively manage paravalvular leak. It molds to the surrounding anatomy and ultimately recruits tissue ingrowth to provide a permanent seal. And this is the model from a ventricular view of the Navitor valve, and you'll see that despite multiple anatomical iterations of the valve, you will see now the external Naviseal cuff actively filling in diastole to reduce the risk of paravalvular leakage, albeit in this model. So I'm just going to briefly talk to you about some of the data from the first generation Navitor trial that was presented at EuroPCR in May of this year, presented by my friend and colleague Lars Sondergaard. And essentially this was the trial, this was the first 120 high and extreme risk patients who were presented for CE marking, and this is their 30-day results. So nobody died despite being a high or extreme risk population of a mean age of 84 years. 1 patient had a stroke, 1 patient had a major vascular complication, and 16 patients underwent a pacemaker implant, albeit you will notice that 13 of them already had pre-existing conduction abnormalities. So in a high-risk group of patients, very safe efficacy results. Perhaps the most striking finding from the trial were in these 2 slides. Not only did we have very effective hemodynamics with a single-digit mean gradient both at discharge and reducing further at 30 days with a high effective orifice area, but as you will see on the right here, no patient had moderate or severe paravalvular leak. And of the patients who we treated in the study, over 80% of them had no paravalvular leak, and this was all core lab adjudicated. So interestingly, when we think to the future for our patients, we clearly are concerned about optimal hemodynamics. And what we were quite interested to see, this is randomized data from the American Portico IDE trial. On the left, you'll see the comparison of an intra-annular leaflet valve, the Portico, with a supra-annular leaflet valve, the Evolute series of valves. And you will see identical effective orifice areas and identical mean gradients. When you compare on the right diagram, the Portico valve versus the balloon expandable Sapien valve, you will see that the intra-annular Portico valve compared to the intra-annular Edwards valve has higher effective orifice areas and lower mean gradients. What about coronary access? We touched on this earlier. It's clearly a very important consideration, particularly for younger patients who will undoubtedly increase in frequency to be treated by TAVI. I think we've all been bitten, if that's the right word, by the ReAccess study that was published last year by Marco Barbanti's group. And this was a high-volume TAVI center who cannulated 300 patients both before and after they'd undergone TAVI. And what they found is that nearly 8% of patients could not have their coronary arteries accessed immediately after their TAVI procedure. And what the study went on to show that this was predominantly in the Evolute series of valves. The predictors from their data were, yes, the use of the Evolute valve, sinus valsalva oversizing, together with the depth of implantation into the left ventricular outflow tract, which is clearly in vogue to try and reduce the incidence of conduction abnormalities. And perhaps this pictorial explains why it is the case that the design of the valve is going to be important in our future considerations for coronary access. On the left panel, you will see the low frame intra-annular leaflet that is consistent with the balloon expandable technology that we currently use. In the middle, you will see a high frame intra-annular leaflet type valve, such as the Portico valve, and on the right you will see a high frame but supra-annular leaflet valve, such as the Evolute series of valves. And the pictures show exactly and very easily why we may have issues with coronary reaccess depending on the type of valve that's used. As regards the Portico valve itself, the benefit it has is large cell diameters and cell size, facilitating easy reaccess to the coronaries in conjunction with the intra-annular location of the leaflets. And whether it's right coronary or left coronary access, it is very straightforward given the anatomy of the TAVI valve. So I've talked enough about data. I'm going to show you a case from my hospital in the western part of the UK where it certainly doesn't look like this. Winter is upon us in the UK, and the right lower panel of sunshine is, we won't see that again until next year, unfortunately. So I'm going to show you a case. This exemplifies the use of the valve, I think, best. So this is a typical high-risk patient, an 87-year-old female, high risk scores, both STS and Euroscore 2, preserved left ventricular function, and valve parameters consistent with severe aortic stenosis. In terms of the CT anatomical details of her valve, this is a severely calcified valve. The Agatston score is 3,705. All leaflets are affected. And you'll see the aorta itself is diffusely calcified, although the ascending aorta appears to be relatively spared. And the anatomy is verging on a vertical aorta. The iliofemoral anatomy is of large caliber, but it's diffusely diseased with both plaque and calcification, albeit non-tortuous. So therefore, we felt this was suitable for transfemoral TAVI. So our procedure plan was to deliver a 27mm Navitor valve under local anesthesia, ultrasound-guided vascular access, a 15 French femoral sheath with ProGlide pre-closure, and a 20 millimeter balloon pre-dilatation in view of the calcified nature of the trileaflet aortic valve. So this is the valvuloplasty with the 20 millimeter balloon. You will notice that the inner curve of the aorta does appear calcified on angiography, in keeping with the age and risk of the patient. You will also notice this is a coplanar LAO view. We then move to a cusp overlap view, left-right cusp overlap view to perform the valve implant. So this is what the Navitor valve looks like angiographically. This is the starting blood pressure. And this is the valve being unsheathed. So because it's an intra-annular leaflet-located valve, it functions very early on deployment, therefore rapid pacing is not needed, and that is the real-time deployment of the valve that you're watching. So a very simple and hemodynamically stable procedure, which means from a patient comfort perspective, this is usually very well tolerated. We then, as per normal practice, perform an aortogram to check the position of the valve here, and again the blood pressure has remained unchanged for this patient. We're then happy with this location, so we'll go on to deploy, but at this point this valve is entirely functional, but it's also entirely repositionable if we're not happy with the position of it. This is the release of the valve from the delivery system, slow, stable deployment, so that the 3 retainer tabs at the proximal end of the valve are released, and then we will go on to assess in typical fashion with aortography, echocardiography, and hemodynamic assessment the result of the valve to check that we don't need to post-dilate, and we didn't in this case. The blood pressure on the left side of the diagram shows that the blood pressure has remained unchanged throughout this procedure. We then perform the femoral digital subtraction angiogram to check on the patency of the femoral arteries, given that this lady had quite diffuse atherosclerotic change, and therefore we're happy that this is an effective closure with the ProGlide pre-closure as previously determined. The final echocardiogram shows a peak gradient of 12, mean of 7, no aortic regurgitation, and electrically, both PR and QRS durations remain unchanged. So in a high-risk patient such as this, a very stable and simple procedure, hopefully to optimize the outcome for this patient. So to conclude, I would sort of sum up by asking what we actually want from our TAVI procedures in the post-COVID-19 era, and what, more importantly, does this new valve system potentially provide? Well, I think firstly, for the whole cath lab team, this is a delivery system and a valve that's both easy to prepare, load, and for the operators use. It's certainly a delivery system that minimizes the risk of vascular complications with lower profile hydrophilically coated delivery system. It also facilitates the accuracy and the predictability of valve placement, which I think facilitates first-time valve implantation. That accuracy is also needed to reduce conduction abnormalities and certainly reduce the risk of pacemakers. Looking more into the future, we also need optimal hemodynamic valve function for long-term valve durability. So we need large effective orifice areas, low gradients, and minimal PVL. And the combination of these factors will hopefully and likely increase valve durability. Thank you very much.